The management of acute limb ischemia. Comprehensive approach to a time-sensitive vascular emergency. Welcome to today's episode, where we delve into the management of acute limb ischemia, a true vascular emergency demanding swift action and clinical expertise. Acute limb ischemia is characterized by a sudden reduction in blood flow to a limb, posing an immediate threat to its viability. Prompt recognition and intervention are essential, as the window for saving the limb and the patient's life is limited. Initial assessment and diagnosis. Time is muscle. The first step in managing acute limb ischemia is to confirm the diagnosis, assess the severity, and begin stabilization. Clinicians rely on 6 hallmark features, often referred to as the 6 Ps. These include pain that is frequently severe and disproportionate to physical findings, pallor, signifying a pale, waxy appearance, pulselessness, which means no palpable pulse beyond the blockage, poikilothermia, where the limb feels cooler than its counterpart, paresthesia, described as pins and needles or numbness, indicating nerve involvement, and paralysis, the inability to move the limb or digits, which is an ominous warning of advanced ischemia and impending tissue death. A thorough history is crucial. Key questions cover the onset and duration of symptoms, previous episodes of leg discomfort on exertion, known cardiac rhythm disturbances such as atrial fibrillation, recent heart attacks, aneurysms, or trauma. The physical examination should be meticulous. Palpate pulses from the top of the leg down to the feet. Employ a handheld Doppler device to check for arterial signals, and always compare findings to the opposite limb for context. To guide urgency, clinicians use a classification system, originally known as the Rutherford classification. This framework sorts cases into degrees of threat to the limb. In brief, a viable limb is not immediately threatened and intervention can be planned within days. Marginally threatened limbs require urgent action within hours, while immediately threatened limbs demand emergency revascularization within minutes to hours. If the tissue loss is inevitable, the limb is considered non-viable, and amputation may be required to save the patient's life. Immediate management and workup. Once acute limb ischemia is identified, immediate stabilization is paramount. The administration of intravenous unfractionated heparin is the cornerstone of initial medical management. Heparin helps prevent further clot formation, preserves collateral circulation, and reduces the risk of embolic complications during subsequent interventions. Additional supportive measures include fluid resuscitation to correct dehydration and support blood flow, effective pain control often with opioid analgesics, and careful positioning of the limb. The affected limb should be kept lower than heart level and shielded from pressure or trauma, avoiding the use of heat or cold packs. Diagnostic imaging follows stabilization. Bedside Doppler ultrasound is invaluable for confirming the absence of arterial flow and distinguishing severe from irreversible ischemia. Computed tomography angiography is now the imaging modality of choice at many centers, offering rapid, detailed visualization of the blockage, its location, and the condition of surrounding vessels. In stable patients, duplex ultrasonography may also be used, though it is more operator dependent. Conventional angiography, once the gold standard, is typically reserved for cases in which an immediate endovascular procedure is planned. Revascularization strategies. The approach to restoring blood flow depends on the underlying cause, the anatomical level of blockage, and any existing medical conditions the patient may have. Decisions are made by vascular specialists, who select the most appropriate method for each case. Endovascular, or catheter-based, therapy is often the first-line treatment for suitable blockages, particularly those with less severe or shorter duration symptoms. Catheter-directed thrombolysis involves threading a catheter to the side of the clot and infusing a medication directly into the blockage to dissolve it over several hours. This method is best suited to fresh blockages in native arteries or bypass grafts. It is less invasive and allows treatment of blockages in smaller vessels that may be inaccessible by surgery. However, it is not suitable for patients with active bleeding, a recent stroke or operation, or for those with very advanced ischemia, as it may be too slow to prevent tissue death. There is also a risk of serious bleeding, including within the brain. For more urgent cases, percutaneous mechanical thrombectomy offers a faster alternative. This technique uses a device to physically break up and remove the clot, sometimes in combination with low-dose clot-dissolving medication. Surgical revascularization remains the preferred approach for cases of severe or irreversible limb threat, or when catheter-based treatments are not feasible or have failed. Surgical embolectomy. Using a balloon-tipped catheter is the classic procedure for removing a clot caused by an embolism, such as one arising from atrial fibrillation. Bypass surgery may be required if there is long-standing narrowing of the arteries due to atherosclerosis, and the blockage cannot be resolved with less invasive methods. Hybrid procedures, combining open surgery and catheter-based techniques, are increasingly employed to address complex blockages and underlying arterial disease. Post-revascularization care and complications after restoring blood flow. Vigilant post-procedural care is essential. Patients are closely monitored, often in a high-dependency unit. Anticoagulation therapy continues, with many transitioning to oral medications such as warfarin or direct oral anticoagulants, particularly if the blockage was caused by an embolism. One major complication to watch for is compartment syndrome, which can occur when blood rushes back into the limb, causing swelling within the confined compartments of the leg. This can result in nerve and muscle damage, heralded by severe pain on passive stretching, numbness, and palpable tightness. Emergency surgery to relieve the pressure, known as fasciotomy, may be required. Long-term management focuses on addressing the underlying cause. Patients with embolic blockages, commonly from cardiac sources, require sustained anticoagulation to prevent recurrence. Those whose blockages resulted from pre-existing arterial disease need antiplatelet therapy, cholesterol-lowering medications, and lifestyle modifications such as quitting smoking and controlling diabetes or high blood pressure. Regular follow-up and surveillance for underlying arterial disease are also important. Conclusion. In summary, the management of acute limb ischemia is a race against time. The key principles include prompt recognition based on clinical features and Doppler assessment, immediate anticoagulation, accurate categorization of limb threat, and timely revascularization using the most suitable method for the individual patient. Careful monitoring for complications such as compartment syndrome is crucial to ensuring the best possible outcome. With coordinated multidisciplinary care, even the most severe presentations of acute limb ischemia can be managed effectively, preserving both limb and life. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.